Ladies and gentlemen, welcome to our ASPED webinar. So on behalf of the Arab Society of Pediatric Endocrinology, I would like to welcome you today in one of the important webinars that we are carrying on in our second wave of webinars. You know, the Arab Society of Pediatric Endocrinology and Diabetes is a non-profit organization, and our aim is to ensure a high standard of care and development in the field of pediatric endocrinology and diabetes in the Arab region, extending from the Gulf through the Northern African countries. And we want to advance pediatric endocrinology and diabetes by promoting research, education, and medical practice to the benefit of child and adolescent health throughout the Arab region. We carried on the first wave of webinars during the COVID era, and we extended that to the second year after that. And now we are in 2024 running the second wave of very important and educational webinars that we would like that you attend all of them. In case if you cannot attend one of them, all of our webinars are recorded on our website, and you can visit that through the website www.asped.net. We welcome you and we encourage you to become a member if you're not already a member. Right, so today we're going to have a very interesting one. It's going to be about challenges and solutions in growth hormone treatment with three very distinguished speakers, Prof. Asma Deeb, Prof. Jesus Argente, and Professor Ibrahim Al-Alwan. Before handing over the platform, let me introduce our first speaker, Prof. Asma Deeb, which is a very well-known figure, and I'm sure that all of you know her. So Prof. Asma Deeb, she's got more than 25 years of extensive experience in the field of pediatric endocrinology. She's working in one of the renowned medical facilities across the Arab region. She's based in Abu Dhabi in the United Arab Emirates. Her special interests are the use of advanced technologies in treating diabetes and disorders of sex differentiation. She has authored over 120 publications and research papers, and she's associate editor of the ASPED Pediatric Diabetes Journal, as well as editorial board member of the American Diabetes Association Journal. In addition to her clinical role, Dr. Deeb is a clinical professor of pediatrics at Khalifa University and Gulf University. She is the president of the Arab Society of Pediatric Endocrinology, and she's holding other responsibilities and roles with other societies, international societies across the globe. So without taking further, the floor is yours, Prof. Asma Deeb, and we would like to hear from you about the long-acting growth hormone. So please.
Thank you very much indeed, Hussein. Thank you for this kind introduction. And I'm delighted to participate in the growth webinar of the monthly ASPED webinars. It's a great pleasure to have Prof. Jesus Argente with us, as well as Professor Ibrahim Al-Alwan. I would like to start the webinar by my talk, which will be around 20 minutes, 25 minutes, and then I will hand over to Prof. Argente, where you will hear about interesting novel genetics and clinical causes of short stature, and then we will have an interactive session led by Prof. Al-Alwan about some complex and interesting cases. So thank you again. So ladies and gentlemen, I think it's needless to say how complex the journey of people or of patients who are diagnosed with growth disorders and are prescribed growth hormone for their therapy. Right from the presentation, more often than not, the presentation is highly non-specific and very difficult to highlight it purely on clinical ground. Diagnosis is not really easy because growth hormone stimulation tests can sometimes, it's quite an invasive, intensive test and not always reproducible. There is a lot of controversy about which stimulant, what age to prime, and what sort of peak that we can take for diagnosis. And then which growth hormone preparation and how to monitor and the follow-ups, as well as going through the adolescent years and the very important and critical issue of adherence, as well as the cost. So it's not an easy journey that these children have. And then if I'm trying to click, okay. So this is just a summary of the challenges that people go through in the journey of growth hormone diagnosis. And the journey or the challenges I'm talking about are not only challenges for patients who are taking the medicine, but they are also challenges for us as healthcare professionals. Starting from diagnosis, we at our region, we do not have specific growth charts, and this can be challenging. There are some national growth charts like those in Saudi Arabia and Algeria. I think Egypt as well have developed theirs. So we don't really know what's best to use in a country, for example, like UAE. Oman, maybe you have an easy choice of the WHO growth chart being one of the countries that was involved in supplying data to produce those charts. So growth chart is a historical challenge that people have. Now, the other issue is we don't actually have a unified guidelines. And I'm talking about our region, talking ASPED countries. I mean, we have 18 countries, and a big chunk of it is in the Gulf area, and there are no unified guidelines. This leads to issues when we attempt to build registries or when we try to put researches, multicentric research together. Now, with the area that has a high level of consanguinity, it's expected that genetic causes of short stature become predominant. However, we don't really have clear guidance on how and when to investigate suspected genetic disorder. We could help in reducing that huge list of the term idiopathic short stature if we know when and which test to use for detection of the underlying genetic disorder. Another challenge that we have, considering that small for gestational age is an approved indication for growth hormone deficiency, is there isn't really a formal or a structural program to capture those youngsters and get them referred in time. But on many occasions, we get those who fail to catch up, small for gestational age, appearing in our clinic, not very far from pubertal age. So that's another gap. Cost is never gonna go away, and insurance, our battles with insurance are not pleasant, they're time consuming, again, a major challenge. And I'd like also to pause at the very important challenge in medication, not restricted to growth hormone, but to all those medications which require treating a chronic disease. And not only chronic disease, but a chronic disease that needs injection as a modality of treatment. So we have been trying in the Gulf region over the last 10 years. It's almost a decade now since we have been running all those elite meetings, all those consensus statements, and all those pleas for guidelines. So we've met around different countries and we produced different consensus statements and trials for coming up with guidelines, either through our own key opinion leaders or with external guests, like people like Martin Savage and other senior people from around the globe. People like Prof. Martin, Ian Martin Witt as well, and many others like Prof. Argente, who's gonna speak to you today. We also had many efforts producing booklets and leaflets, distributing them at primary healthcare centers, alerting them to, for example, the simple issue of those children who are short and are born small for gestational age. We have also done a lot of work when it comes to digital platforms and how we can utilize those to promote adherence. So, for example, this is one of the studies that we had undertaken between multiple Gulf countries, 8 participating centers. We wanted to explore to what extent digital solutions and digital devices that can be recordable, to what extent that can help adherence. So a lot of effort when it comes to these challenges. So to summarize, growth hormone is a highly effective treatment to improve height for multiple indications. It is safe. We have a lot of long-term data encouraging us to use it. However, the treatment is quite burdensome and it's difficult to sustain the way it should be. Adherence, even when it starts well, at the beginning, the first year, most of the children show better growth velocity in the first year of treatment, but it declines over time. This enthusiasm fades away. And the question that is posed for today's first talk of the webinar is, does long-acting growth hormone improve treatment burden and adherence? This is the question. So we've been hearing over the last few years about the new modalities of growth hormone treatment and how molecules can be altered to affect their pharmacodynamics and kinetics to prolong their duration of action in an attempt to use them less often than daily. And with that, there's a bit of history in this slide where it shows that the first treatment of growth hormone was long time ago, 1958. And then there was a journey of growth hormone treatment approval, and then quite a few preparations of long-acting growth hormone appeared, even in the 20th century. We have some of those, some withdrawn from the market, some got better modified, like those from Korea and China. And then we have multiple ones that are available in the market today. In United Arab Emirates, we have a reasonable experience now with Ngenla, somatrogon by Pfizer, and we are building the experience. And our initial observation shows that it is a satisfactory mode of treatment based on questionnaires that are requested from parents to fill. And we are working in multiple centers to see the efficacy as well as treatment satisfaction as expressed by patients. So long-acting growth hormone, there are many ways of preparing growth hormone to be long-acting. I'm not entirely sure what the formulae that are available out here in the Gulf. I would love to hear from Hussein and Dr. Ibrahim, and perhaps Jesus can tell us about the status in Europe. So multiple types. It's very interesting when we see things related to drug discovery and drug making. It's a very interesting area and very clever how the molecules are played with by different ways, like adding fusion proteins, for example, to prolong the action in somatrogon, or adding fatty acid for fatty acid binding in somatostatin by Novo, and many other ways to convert the molecule into a long-acting one. So when talking about long-acting growth hormone, there are basically 3 main questions. The first one, is it as effective as daily growth hormone? This is a logical question. that comes, number one. Number two, does it really reduce treatment burden? This is a very important question. And then, is it safe, or at least as safe as the daily growth hormone? The summary of the evidence for these three important questions is that in terms of efficacy, so far all published studies demonstrate at least non-inferiority of long-acting growth hormone compared to the daily. And it's obvious for the treatment burden if we talk adherence and talk about the impact on patient's life. A person who injects once a day will be injecting 365 injections rather than injecting 52, the weekly one. So it makes sense to go for the weekly one. The safety, perhaps the long-term studies are not as long as the ones with the daily that's available in the literature, but so far the studies done looking at the safety did not show any new or previously unreported safety concerns. Now, the molecule of somatragon, for example, and the reason why I'm talking about somatragon, it's licensed and approved in United Arab Emirates. I haven't tried any other type of growth hormone, long-acting ones. I would love to hear from you. But somatragon half-life is estimated to be from 5 to 10 times longer than somatropin. Hence, it can be used weekly. And as you can see in the graphs, just going to try and get a pointer. You can see that, here you go. You can see that the medicine in hours, it peaks at around 12 hours after injection. And IGF-1 shows a dose-dependent increment. And that's an important point for the next slides that I'm going to show you. Now, there is lots of studies on the molecule. So in phase 2 study, where there was an attempt to know the dose curve and where the best dose that will be equivalent to the daily somatropin one, as you can see here, 3 doses were tried, 0.25 milligram per kilo, 0.48 milligram per kilo, and 0.66 milligram per kilo per week. And this is the dose that is found to be closest to the daily one when the annual growth velocity, which is, you can see on the y-axis, that is achieved. So currently, the instructions are to use 0.66 milligram per kilo per week. And there are 2 preparations, the 24 pen or milligram pen or the 60, and I'm sure many of you have seen them. So this is phase 3. It's quite a spread trials, clinical trials around the globe involving almost all continents. And these are the some of the results that shows what happens when patients were switched from daily to weekly. So there isn't really any statistically significant difference, which shows that the long-acting confirmed the non-inferiority to the daily one. So I don't have time, and I don't want to bore you going through the studies one by one, but to summarize what I've seen in the literature in relation to somatragon weekly treatment is that this innovative formulation may help improve adherence, which is a big challenge in the treatment. And there are now several technologies that are used to prolong the growth hormone. And not only that, the expectation is it will improve adherence, but also treatment outcome. We've quickly seen 2 slides showing phase 2 and phase 3, and nowadays there are long-term data up to 9 years, to the best of my knowledge. And those studies confirmed the non-inferiority in which somatrogon weekly compared to daily somatropin were comparable. Now, before I hand over to our next speaker, I just have a couple of slides that is related to clinical application and the day-to-day use of growth hormone for us healthcare professionals, because we are used to the daily one, and the patients come and we ask for IGF-1. It doesn't matter which day they have it, what time they have it, but this is an issue, an important issue when it comes to the weekly one, because with IGF monitoring, there is a certain curve for the weekly hormone. So what the PDPK studies showed, ideally, IGF-1, blood for IGF-1 should be drawn on day 4, and I'll show you why in the next study. We know sometimes this is not feasible or not practical. We have clinic and patients might come from a far distance. So what if a patient does not come on day 4 and cannot do it on day 4? Then if that's the case, there are ways to calculate or to estimate day 4 level. Now we can use IGF-1 to adjust the dose, and if the IGF-1 was done properly and calculated for day 4 and it was high, then the recommendations is to reduce the dose of 0.66 milligram per kilo per week by 15%. Now, there is an interesting point here from the practical point of view, in that if the patient chose, for example, Friday as the day of weekly, and let's say he or she was not able to inject on Friday, then according to the manufacturer, we can change the day as long as we keep at least 72 hours between the 2 injections. So if the medication was given on Saturday, you can give it on Tuesday if the next Saturday is going to be difficult. So we have a window of 72 hours that we can keep between the 2 injections, and that adds the flexibility for patients and improve the adherence. So this is where the day 4 IGF-1 sampling comes from. So if we look at this PD profile, the pharmacodynamic for these are days. So the x-axis is days after dosing, and this is the IGF-1 SDS. Now, day 4, indicated here by the blue dot, is where we see the 0. In other words, if people take the sample on day 1 or on day 2, there might be an overestimation of IGF-1 level, and vice versa. If the sample was taken on day 5 or day 6, there might be underestimation. So ideally, we hit the 0 SDS on day 4. But what if we cannot hit? Well, I'm not gonna go through this, but this is a way of how to calculate the day 4, estimating day 4 IGF-1, should the patient have done it before day 4 or after. So your colleagues, your Pfizer colleagues can help you getting this and help you to calculate so that we know the exact way of IGF-1 use. So this is my last slide, ladies and gentlemen. I hope I didn't bore you with this, but I just like to restate how challenging diagnosis of growth disorders are, and how complex the treatment is, and how difficult the journey of the patient can be. We remain with issues of adherence, so attempts of reducing or improving the adherence by ideas like long-acting or the digital devices or other ideas are really valuable to improve that. And long-acting growth hormone, being non-inferior to the daily growth hormone, can provide an effective and safe way for treatment for growth hormone deficiency. And with that, I hand over back again to Hussein, and thank you very much indeed.
Thank you very much for this opening talk about very important treatment. And thank you very much, Prof. Asma, as usual. Very fascinating talk. So next lecture is going to be about the novel genetic and clinical causes of short stature with Prof. Jesus Argente. Let me introduce Prof. Jesus to you guys. I'm sure that you know him, very well known international speaker. He's professor and director of the Department of Pediatrics at the Universidad Autónoma de Madrid, so from Spain. He's director of the Department of Pediatrics, chairman of the Department of Pediatric Endocrinology, and director of the Laboratory of Research in Nino Jesus University Hospital in Spain. Prof. Jesus, he obtained his medical degree at the University of Zaragoza and completed the pediatric residency at the Hospital Ramon y Cajal in Madrid, and has worked at the Hospital Saint Vincent de Paul in Paris, France, and the University of Virginia and in the US, and University of Washington in Seattle in the US as well. His main research interests including childhood obesity, pathophysiology of human growth, puberty, eating disorders, and diabetes. He has published more than 300 original articles and has lectured in more than 30 countries. He is past president of the European Society of Pediatric Endocrinology and past president of the Spanish Society for Pediatric Endocrinology, SEEP. He has obtained multiple national and international awards for his research. So, without further delay, Prof. Jesus, the platform is yours.
Thank you very much, Dr. Al-Safar. I would first like to thank everyone from the Arab Society for Pediatric Endocrinology and Diabetes for this kind invitation, and particularly to Dr. Asma Deeb. I'm very happy to be with you again. And I will talk today about novel genetics and clinical causes of short stature. I have nothing to declare. Here is my outline. So I would like to analyze the molecular basis of genetic short stature and to concentrate in different kind of gene abnormalities that we have during the last year doing a lot of research, which is children with PAPA2 deficiency, with RNP53 variants and SL2 and SMC5 variants. And I would like to send some clinical messages, some research messages, and some translational research messages to all of the pediatric endocrinologists that are listening. So as everybody knows, prenatal and postnatal growth in humans is particularly special and different compared to other mammalians. We don't know really very well how prenatal growth is actually done, but we know that insulin, growth factors, maternal health, nutrition, and placental function are quite important to develop normal fetus. And we also know that in the postnatal growth, during infancy, nutrition is quite important, as well as the growth hormone regulation and thyroxine. And during puberty, during the growth spurt, we know that sex steroids, together with growth hormone, are going to play an important role. In Spain, we have different growth charts specific for our population. Then they are very, very close to the curves from the CDC in the States. So we have approximately the same centile 50 for girls and also for boys. So genetic short stature is indeed a very complex medical and scientific issue. In fact, during the last 2 decades, we have discovered many monogenic cases of growth disorders, including children with prenatal and or postnatal short stature, mild or severe, due to abnormalities in the growth hormone IGF axis, due to skeletal dysplasias or specific syndromes, showing that, in fact, the genetic causes of short stature are highly heterogeneous. However, a relevant number of children with SIR stature still do not have a specific diagnosis. We know that the new generation sequencing techniques are discovering and will discover in the future more genes implicated in the regulation of human growth and benefit the patients by allowing management and counseling specific for the disorders, and may reveal novel treatment approaches. Here I'm showing you the a typical picture of the growth hormone regulation in humans, introducing new players, specifically the papalysins and also the stanniocalcins. We know that growth hormone will produce IGFs, IGF-BPs, and the protein ALS. And then we will have in plasma just IgF molecules alone, or in a binary complex with IGF-BPs, or the most common one with a 3-molecular complex, including IGF, either 1 or 2, IGF-BP plus ALS. So this 3-molecular complex circulates in plasma, and papalysins, specifically PAPA and PAPA2, will liberate the molecule of IGF-1, and then this molecule, through its receptor, will regulate growth in an autocrine or paracrine manner. In addition, IGF alone can regulate growth in an endocrine manner. Therefore, this is a quite complex mechanism that we are trying to understand better during the last year. In this cartoon, I'm representing what we know today about the human genetic SIR stature, including not only patients with isolated growth hormone deficiency and the different kinds, but also patients with abnormalities in the minor spliceosome due to variants in the RNPC3 gene, as we will discuss later, and also patients with combined pituitary hormone deficiencies, including variants in POE, F1 gene, PROP1, LH63, LH64, or HEX1. And also, we have recently discovered abnormalities in the IGF-1 gene, also in the ALS, also in the IGF-2, and more recently in PAPA2, that we will talk about it immediately. So, regarding PAPA2, you know that this is a metalloproteinase of about 1,791 residues, and PAPA2 specifically clips not only IGF-BP5, but also IGF-BP3. So the first patient that we saw in our department, it was a girl, 9-year-old female, that was brought to our attention for a possible SIR stature. In fact, when we analyzed her, she was in a centile 10. However, the target height was in a centile 50 to 75. This is an important issue to analyze. So the delta target height versus height was about 1.7 standard deviation. She was thin, with a modest microcephaly around 2.2 standard deviation, but it was impressive to see the IGF-1, IGF-BP3, and ALS levels were dramatically elevated. I never ever seen something similar, with IGF-1 levels around 1,000 nanogram ml. When we analyzed the IGF-1 levels in the parents, they were in the normal range. And the cranial MRI was completely normal. So here is the phenotype of this girl. And when you look at the growth chart, you can see that she was slowly diminishing the growth velocity. So when we see her the first time, it was in a centile 10, while the target height was in a centile 50-75. We had a lot of discussions with American colleagues, because they say, okay, well, if the patient is in ±2 standard deviation of height, there is no reason to study genetically this patient. I think they are wrong, because when the height is very far away from the target height, it means that there is something pathological that we need to analyze. Her brother, he was born small for his gestational age, but he did a very nice catch-up growth from the beginning. And again, he was growing slowly. And when we when I see him the first time, he was in a centile 10 to 25, once again, far away from his target height. So here are the levels of the IGF-1, IGF-2, BP3, and ALS, and also the growth hormone secretion that was very elevated. So we thought, well, maybe there is an abnormality in the IGF-1 receptor gene, but this gene, the sequence of this gene was completely normal. Therefore, we decided to perform a full exome, and in this full exome about the potential candidates, we found the abnormality in the PAPA2 gene, which is in chromosome number 1, and we found a mutation in homozygosis, pathogenic, with a frame shift and an AT insertion that produced an stop codon, as shown here. So when we analyzed the patients and the family, the parents were non-consanguineous, were heterozygous for the mutation, and they had 4 kids. So 1 girl and 1 boy affected, 1 girl unaffected, and 1 girl in heterozygosis. So performing functional studies of PAPA2 protease activity, you could see that the wild type of PAPA2 clips not only IGF-BP3, but also IGF-BP5. However, the mutated variant saw no proteolytic activity at all for IGF-BP3 or IGF-BP5. So we hypothesized that the lack of PAPA2 will produce an increase of ternary complex, a decrease in free IGF-1 and free IGF-2 levels, and this decrease will produce feedback increasing growth hormone secretion, and therefore increasing IGF-2, IGF-1, IGF-BP3, ALS, and IGF-BP5. So to prove that, we performed ternary complex, we analyzed ternary complex formation by cross-linking and by chromatography. And as you can see in the upper part of the slide in red, the 2 affected, the girl and the boy, you can see that the ternary complex were extraordinarily elevated when compared to the other sister, the heterozygous one and the healthy one. Both these girls exhibit at prepubertal ternary complex levels. In order to analyze more potential data, and in conversations with our friend and colleague, Dr. Rosenfeld, we could find a family from Palestinian origin living in the States that was controlled initially by Dr. Desikan at the New York Medical College, and later for Dr. Musunder at the Pittsburgh Children's Hospital. And they had DNA of this family, and we could study this family together with Dr. Wan and Dr. Dover at the Cincinnati Children's Hospital Medical Center. And we found another mutation in homozygosis. As you can see here, this family is consanguineous with 5 children. They had 2 males affected, 1 female affected, and 2 females in heterozygosis. So when we analyzed the data in blue, we found the same thing. So growth hormone levels were very high, IGF-1, IGF-2, BP3, ALS were very high. And interestingly, we measured PAPA2 levels in plasma. The Spanish patients, in the Spanish patients, PAPA2 was undetectable. And in the Palestinian patients, PAPA2 was very, very low. In addition, we analyzed free IGF-1 levels. This is quite important to better understand the regulation of the growth hormone IGF axis for different methods, including the KIRA method in collaboration with Jan Fistek in Denmark. And we found very, very low levels of free IGF-1 in these patients. At that moment, we knew that we had some experience with cow PAPA2 animal models, not only in mice, but also in zebrafish. Therefore, we decided to perform a radiological survey, and we found in these patients, here you have the Spanish one, and here you have the Palestinian one, we have a fine skeletal structure with thin, long bones, small chin, and long, thin teeth. In addition, in the densitometric studies, we found that the bone mineral density in the lumbar area was in the range of osteopenia in the male and osteoporosis in the female, with normal low trabecular structure and normal low total body fat. We had the opportunity to study in collaboration with Dr. Susanna Jakar in New York. One of the tooth of this patient, and as you can see, our PAPA-2 patient exhibits or demonstrates a clear decrease not only in the enamel, but also in the dentin density when compared to a control in the upper part. So, could we do anything for these patients? Obviously, we did not consider the possibility to treat them with growth hormone because they have very elevated growth hormone levels. And then we try to treat these patients with recombinant human IGF-1. The response of our female patient was extremely good, as you can see, and she is already out of therapy after several years, and she reached the target height. Regarding the boy, the response was extremely good. He's still under recombinant human IGF-1 therapy, and he already has a better height compared to the target height. No hypoglycemias were seen during the treatment of these patients. So later, we had the opportunity in collaboration with Dr. Amir Babiker and also Ibrahim, Al-Alwan, and different doctors in Saudi Arabia to study a new family that we published in Clinical Genetics with a new mutation in exon number 7 in a family, consanguineous family, with this pedigree, where we found 2 patients with homozygous pathogenic mutation in PAPA-2. And as you can see, this patient probably will have more information today, but his response to human recombinant IGF-1 therapy was very, very good. And previously, he was treated with human recombinant growth hormone with no response. This data is extremely important. We cannot treat the other patient because he had already adult height, and he had a very, very low height compared to his target height. So in summary, from 2015 till 2024, we have discovered different abnormalities in the PAPA-2 gene. First of all, in the Spanish family, as shown before. Secondly, this Palestinian family. And finally, in this Saudi Arabian family. So with a total of 7 homozygous patients with a similar phenotype, with similar growth hormone IGF alterations and similar DEXA abnormalities. And right now we are studying different patients from other countries like Colombia, France, and other countries in Europe with mutations in PAPA-2. So we need to try to identify these patients. They do exist, and we have possibilities to treat them. So to finalize this part, the clinical messages would be: first, in patients with short stature and elevated IGF-1 levels, serum PAPA-2 levels should be determined. This is cheap, this is fast, and can give us an important information. If PAPA-2 levels are undetectable or very low, then genetic studies should be performed to analyze potential abnormalities in the PAPA-2 gene. Second, the PAPA-2 gene has been added to the molecular basis of growth failure internationally. Third, long-term treatment with recombinant human IGF-1 improves growth in patients with PAPA-2 deficiency. This is obviously my personal experience. And finally, it has been include this abnormality called stature Dover-Argente type in the OMID database within this locus number as shown in this slide. The second part of my talk will be devoted to the RMPC3 gene. So we had the opportunity to see this family from Romanian origin in my department. And after the reason was short stature, of course, and after analyzing all of the clinical biochemical data, we got the diagnosis of severe isolated growth hormone deficiency. See, this girl, 10 years and a half, and the older girl, 15 years and a half, much smaller, much shorter, and these other girls, 6 years old and 8 years old, very short stature. So the bone age was very delayed, and we found pituitary hypoplasia, and we have decided to study the normal genes that could be involved in either isolated or combined pituitary hormone deficiencies, including GH1, GHRH receptor, PROP1, PO1F1, LHX3, and LHX4. All of them were completely normal. So then we decided to perform a full exome in order to analyze other genes. And we found a couple of mutations in heterozygosis, as shown here, R502X and P474T, in the protein of 60 kilodaltons between U11 and U12, corresponding to mutations in the RNPC3 gene. This resulted in abnormalities in the minor spliceosome formation and incorrect and/or incomplete splicing of a variety of MRIs in patient cells. It is important to know that today we know different diseases, particularly cardiopathies and neurological diseases, due to abnormalities in the minor spliceosome. And this is the first time that we saw abnormalities related to isolated growth hormone deficiency. Today, in the OMIN database, mutations of the RNPC3 genes are included as type 5 of isolated growth hormone deficiency. But here you can see the response of these patients to growth hormone therapy was spectacular. And when you look at the oldest girl here, see, even with a chronological age of 20 years, she was still growing due to the fact that this huge delay in bone age, 15 years old, as you can see here, going from a height in almost in -6 standard deviation to a current height in -0.1, which is the target height of the family. The second one responded extremely well, as you can see here, as well as the third one. But analyzing these patients, when they arrived to puberty, the first one saw delayed puberty with a potential hypergonadotrophic hypogonadism, and the second one, hypergonadotrophic hypogonadism. This is the reason why we had several conversations with my friend and colleague Meul Dattani in London, and we decided, together with another colleagues like Mohammed Magni and other colleagues from Moscow, like Anatoly Tulpakov, to investigate 9 different pedigrees of patients with RNPC3 mutations, a total of 15 patients from different countries in Europe. And then we decided to analyze the rest of the pituitary hormones to see whether or not we could find abnormalities other than growth hormone deficiency. And interestingly, we found that these patients could have hypopituitarism and also primary ovarian insufficiency. We hypothesized with these 15 patients that the splicing defects in genes involved in ovarian development or function may be implicated in primary ovarian insufficiency in female patients with RNPC3 mutations. So this is something that we are right now investigating, and we have a potential gene that is AUP107 that seems to be a strong candidate to possibly explain the primary ovarian insufficiency. So as happened in patients with mutations in PO1F1 or PROP1, our children can acquire deficiencies in pituitary hormones during childhood. Here you can see on your left a patient from Russia, this courtesy of Dr. Tulpakov. You can see a typical phenotype of growth hormone deficiency. She was under therapy. She is right now being treated with growth hormone with an excellent response. And on your right, you have a male, this is courtesy of Dr. McNee, with an excellent response to growth hormone and also with a pathogenic mutation in RNPC3. So we are seeing different patients in different countries, and we are seeing that they all respond very well to growth hormone therapy. So how about the clinical messages of this second part? First, the effective minor spliceosome mRNA processing should be studied in patients with severe familial and isolated growth hormone deficiency where no classical causes are found. Second, this results in abnormalities in minor spliceosome formation and incorrect and/or incomplete splicing of a variety of MRIs in patient cells, including some genes coding for proteins involved in the development of the anterior pituitary. Third, a recent finding suggests that novel insights into the role of RNPC3 in female-specific gonadal function and emphasize a critical role for the minor spliceosome in pituitary and ovarian development and function. Finally, pituitary hormone deficiency combined or isolated, type number 7, are included in the OMIN database if you want to get more information about these patients. So here is just to show you in the final part of the slide that these mutations with in the RNP3 are considered right now by the OMIN database. And the last part of my talk will be devoted to children with short stature and microcephaly. You know that this is a very, very complex area in pediatric endocrinology, including patients with microcephalic osteodysplastic primordial dwarfism, Major Gorlin syndrome, and what is more important, in my opinion, which is the Seckel syndrome spectrum disorders. We cannot talk anymore about Seckel syndrome alone, but the Seckel syndrome spectrum disorders, and also the Bloom syndrome. Those patients are very important because they will exhibit deficiencies in one of the three cellular processes, either DNA replication or DNA repair and mitotic cell division. So although mechanistically are distinct, the common clinical phenotypes are thought to result from a reduction in cell proliferation and or excessive cell death in the developing embryo, reducing normal growth. Importantly, cells of these patients exhibit genome instability with elevated chromosome bricates. Therefore, recombinant human growth hormone therapy must be avoided in these patients because we can create severe problems. So here is a list just to show you that research is moving very fast for the primordial autosomal recessive microcephalies, for the microcephalic osteodysplastic primordial dwarfism. For the Major Gorlin syndrome, we know at least 8 different kinds at this moment. And also for the Seckel syndrome spectrum disorders. And we will add some more genes that I will explain right now. So regarding the diagnosis of this Seckel syndrome spectrum disorder, clinically, they exhibit not only an important short stature, but also microcephaly, a severe microcephaly. There is a brain imaging with reduced brain volume and grossly normal architecture, and a family history of autosomal recessive inheritance. So molecularly, given the high heterogeneity of this spectrum, it is important to perform an AS panel containing all known genes or a full exome, including analysis of copy number changes. So recently, a year and a half ago, in collaboration with Dr. Jackson and Dr. Grant Stewart in UK, we could find 11 individuals in different countries, including UK, France, Netherlands, Japan, one patient in Saudi Arabia, Germany, Spain, and USA, exhibiting pathogenic variants in SLF2, SMC5. And we saw that these abnormalities cause segmented chromosomes and mosaic-variated hyperploidy. Here is one of the patients that I had the opportunity to see with a severe short stature, -6.2, and a severe microcephaly, -5.7 standard deviation. See the face long and narrow with a slight epicanthus fold, prominent nose, slightly low set years, and high palate that you cannot see there. And C exhibit a mutation in exon number 9 in the gene SMC5, producing or being responsible of this syndrome. Here, I'm showing you the structural modeling of this gene SMC5, and particularly this mutation, arginine 372 and histidine 990, which were the more frequent in the population analyzed. In addition, FIS studies show dicentric chromosomes in a metaphase spread from a patient with SLF2, as shown here. And we could study also these abnormalities in this gene in the zebrafics, showing the important issue that they exhibit an important microcephaly. Here are images in mutations in both genes, representing here the most important mutation that we could found after laser microirradiation and analyzing the abnormalities in everyone. So the messages here for translational research is that we have identified biallelic variants in these two genes in 11 patients with microcephaly, short stature, cardiac abnormalities, and anemia. Patient-derived cells exhibit chromosomal instability phenotype with segmented and dicentric chromosomes with mosaic variety hyperploidy. To signify the importance of these segmented chromosomes, we have named this disorder ATLIS, meaning incomplete syndrome. This chromosome instability arises due to the elevated replication stress, partially due to unresolved G-quadruplex DNA structures, and also loss of sister chromatid cohesion. The precise function of SMC5-6 complex remains enigmatic. During DNA replication, we know that they stabilize stall forks. And finally, I would like to show you this family from Equatorial Guinea with an important short stature and a tremendous microcephaly, greater than -10 standard deviation. This patient exhibited also severe intellectual disability and chorioretinopathy with an MRI showing reduced brain volume, cerebellar atrophy, and lissencephaly with pachygyria. So here you can see the height of both patients, and they exhibit a pathogenic mutation in homozygosis in the gene PLK4 that has been discovered in other families recently, also from African countries. So my final messages for young pediatric endocrinologists and scientists in general is that there are still a large number of patients with idiopathic short stature. A complete clinical evaluation should be performed in all cases, including birth weight and length, but importantly, head circumference. We need to teach our medical residents to ask for head circumference at birth and to measure head circumference compared to height in the patient when this patient comes to our office. Third, the underlying cause of short stature should be determined to better treat the patient. Four, clinical observation is one of the most important tools in order to discover new disease causes. If we don't think in this term, we are not going to discover new diseases. So this is extremely important. And finally, even when a specific genetic cause has been demonstrated, the child may develop additional hormone deficiencies during childhood. Therefore, we need to include the study of gonadotrophins that can result in a delayed puberty or hypergonadotrophic hypogonadism. Hence, clinical follow-up is mandatory. And this is something that we also need to teach our medical residents, our young medical residents in training, because this is the only manner to reflect on these patients and to diagnose potential deficiencies during childhood. So, understanding short stature, I would like to say that observation and curiosity leads to research improving our knowledge. And we have the obligation to study all patients with short stature that we do not understand. I would like to thank my colleagues at the Hospital Niño Jesús in Madrid, which is linked to the Universidad Autónoma of Madrid. And also would like to thank my collaborators, including Dr. Luis Pérez Jurado from University Pompeu Fabra in Barcelona, Dr. Freelander from the University of Helsinki, Dr. Natani from the Great Hormone Street Institute of Child Health, Dr. Jackson from the University of Edinburgh, and Dr. Grant Stewart from the University of Birmingham. And of course, I would like to close thanking you for your attention, and with an excellent memory, when I had the opportunity to visit Abu Dhabi in 2020, just 2 weeks before the pandemic. 2 weeks later, Europe was closed, and here you had the friends that are present today, and also you have Dr. Magni here. I can see Dr. Asma, I can see Ibrahim over here. So thank you very much to all of you. It's a great pleasure to be with you again, and hopefully we will have a new talk in person in the near future. Thank you very much indeed.
Thank you, Professor Jesus. Very interesting. You brought memories from by this photo. That's a really nice one. That's, I do remember that one.
Thank you, Jose.
Yeah, well, lovely talk, and we have heard learned a lot from you today. We heard about new genes that I've never heard of before, and we need to be vigilant for those cases. Thank you very much. Thank you. I think Prof. Asma would like to ask some questions related to your presentation. Yes? Yeah, Prof. Asma.
Yeah, well, thank you very much, Jesus. That was really music to our ears, and thank you for highlighting your memory in Abu Dhabi. That was an amazing one. What I thought we would do before we hand over to Ibrahim is just to have a sort of few minutes discussion, and I would like to encourage the audience to post their questions, please, in the QA icon. So, Jesus, just few things about the three main areas that you have discussed, and if I could start with the PAPA mutation first. So some of these questions are very naive, so please bear with me. So things in this interesting, first of all, why the first P stands for pregnancy. What has pregnancy to do with this gene?
Well, PAPA is mainly involved, not PAPA2. And so far, we don't know any specific mutation in PAPA2 associated with short stature. However, PAPA2, we really don't know the physiology during pregnancy, but we know that it's not playing an important role. However, because as I mentioned at the beginning of my talk, because we really don't know how prenatal growth is organized, we must investigate whether PAPA2 could play a role in the growth of the fetus, okay? So all pregnant women exhibit very high PAPA levels in plasma.
Okay.
And this is not associated with any pathology, okay? However, PAPA2 has not been studied. We have some recent data in pregnant women, and they are not elevated as PAPA levels during pregnancy. And we are now investigating, the role of PAPA2 during fetal growth. It's going to take a while because it's very difficult, because as you know, fetal growth is not really related to growth hormone in the uterus, and therefore there are a lot of limitations. But anyway, it's a very exciting field, and your question is not naive, it's a very important one.
Thank you. And these patients, are they born small for gestational age?
No, not necessarily. One of our patients, as I mentioned, the male one, he was small for gestational age, with an excellent catch-up during the first months of extrauterine life. But the rest of the patients I had the opportunity to study, they were not small for gestational age.
Okay. Yeah, that's interesting. Just to continue from this, if you don't mind, you mentioned the advanced bone age in these children. So why they are short and they don't have much of circulating IGF-1? So why is bone age advanced?
No, it's not advanced. It was delayed.
The bone age is delayed.
The bone age is delayed. Then the densitometric parameters are also reduced in range of osteopenia and osteoporosis, and they do not exhibit accelerate bone age. They do not.
Sorry, I might have missed. Just another question. This one must be naive. Now, there is a lot to say about microcephaly and growth disorders in general. But which growth charts do you use? Because majority of the head circumference growth chart of what's available to us ends at year 2. So older children, how can we measure and which charts?
We use a Spanish growth chart for height, weight, BMI, and head circumference. And one important thing is that we need to compare the head circumference compared to the height, because this guy exhibits a very severe soil stature. Therefore, it's not just to measure the head circumference, but to apply compared to the height. And this is the reason why you can obtain a rigorous data about the head circumference. In these patients, you can see, as I showed you before, they had more than -10 standard deviation of head circumference. So this is just a dramatic microcephaly. It's not a modest one in around -2 or something like that. But it's very important, as I said, to learn our young doctors saying you need to measure the head circumference. You need to ask for the head circumference at birth. And you need to analyze this properly compared to head in order to see whether this patient exhibit a pathogenic microcephaly. Because if there is a pathogenic microcephaly, the genetic focus that we are going to have to study this patient is going to be different. If this patient saw normocephaly or macrocephaly. So this is an important issue for diagnosis and also to drive correctly the genetic studies.
One final question, please, Jesus. Now, part of this question is related to a question in the Q&A icon. Now, isolated growth hormone deficiency, we know they respond to growth hormone, and we know many of them have pituitary hypoplasia. So I'm not going to say what's the benefit of doing genetics, but what prompts you specifically, leave the academic benefit aside, to do so? For example, that patient with RNPC3, who, I mean, we have hundreds of isolated growth hormone deficiency children with pituitary hypoplasia. So my question and the question that's in the icon, do we do genetic testing for all these children? What prompts you to specifically ask for genetic testing?
Okay, we are working in a university hospital. Then we need to perform research. If you ask me, what is the benefit of doing genetics in patients with isolated growth hormone deficiency if you are going to treat them anyway with growth hormone?
Exactly.
So the question for someone ignorant would be, there is no reason to perform genetics, there is no reason to spend money, because we are going to apply the same treatment anyway. Okay, the important reason here is, number one, to perform genetic counseling. This is very important for the families, because we know that the pattern of inheritance is different from one abnormality to another. And number two, to learn. I think this is important. And what we have learned, for example, with patients with RNPC3 mutations around our studies, is that these patients can get pituitary deficiencies during childhood. Therefore, you have a patient with isolated growth hormone deficiency due to an abnormality in the GH1 gene. You are not supposed to think about potential deficiencies, pituitary deficiencies in the future. However, if you are in front of a patient with an RNPC3 mutation, you have the right and you have the necessity to continue exploring this patient in the future in order to know whether another pituitary deficiencies could appear. So in my opinion, those are two important reasons if you are working in a university hospital to do research and to analyze, and of course, to increase our knowledge because we are dramatically increasing during the last 10 years the number of genes involved in the growth regulation in humans. And this is academically very, very important.
Absolutely. I'm sorry, I said last question, but there was a very important question coming up to clarify the issue of PAPA-2. People here saying, why did you treat the first patient with the PAPA-2 mutation with IGF-1, even though the IGF-1 and the IGF-BP3 were high? And I think you did say the free IGF-1 is low, but you might as well clarify, please, Jesus.
Very happy to do that. Well, first of all, it was the first time that we have made this diagnosis, and we didn't know whether we could help these patients or not. So our rationale was, number one, it doesn't make any sense, probably, to administer growth hormone because growth hormone is very high. Number two, maybe we could treat these patients with recombinant human IGF-1. So this question is very relevant, and it's very relevant because we have very high total IGF-1 levels in plasma, but most of them is internally complex and is not active at all. So we hypothesize if we administer these patients recombinant IGF-1, maybe we can increase free IGF-1 levels in plasma because the free IGF levels are extremely low or undetectable. And this is the reason why these patients are not growing. So we decided to treat them with human recombinant IGF-1, and we performed pharmacological studies during the first years of treatment, showing how free IGF-1 levels were increasing. Of course, total IGF-1 levels were very, very high at any time of the study, but the increase in free IGF-1 levels made the increase in growth, physical growth in these patients.
Okay, that's brilliant. I'll hand over to Hussein, please. Thank you very much again, Jesus.
Thank you very much. A pleasure.
Thank you.
Can I ask one question, Asma, if you don't mind?
Absolutely. Well,
please go ahead. Yes.
My question is, for the cases of RNPC3, you mentioned that they do tend to have hypergonadotropic hypogonadism. Does this happen early in life, or it comes only just prior to puberty? That's the first part of the question. The second part, did you study the families of these cases where relative of the families have infertility because associated with hypergonadotropic hypogonadism? Thank you.
Thank you. Thank you. But, the two questions are very important. The first one, we studied initially during when they were prepubertal all of the pituitary hormones, and we didn't find any abnormality except the growth hormone deficiency. Of course, we studied the patients when they were arriving to puberty because number one, delay of puberty in the oldest patient, and number two, because we found hypogonadotrophic hypogonadism in another patient. And during the meetings at the ASPED, at the Endocrine Society, etc., I had many conversations with Meul Datani and other colleagues that they have patients like that, similar patients. And then we decided to study all together. And this is where we found that a number of females because there are just a few males, and all of the males we know, they have normal fertility, normal puberty and normal fertility because they are adults. But among the females, most of them, they do exhibit this primary ovarian failure, which is clear, is an evidence, but we don't know exactly the pathophysiological basis of this abnormality. So, in conclusion, during pre-puberty, you cannot say anything about this POI. During puberty, you must study gonadotrophin secretion, and you must analyze whether there is a delay, a normal puberty, or a hypogonadotrophic hypogonadism, as far as we know so far.
Thank you.
You're welcome.
Thank you very much for your discussion, very, very informative. So now we move to the last, perhaps no, before that, we have a session by Professor Ibrahim Al-Alwan to talk about interesting and complex clinical case scenarios, followed by Q&A session. Prof. Ibrahim Al-Alwan, he is very known in the region, professor of pediatrics. Very short period of time, he was the assistant vice president at King Saud Ibn Abdulaziz University for Health Sciences in Riyadh, Saudi Arabia. He obtained his MRCP UK in 1995, the American Board of Pediatrics 96, and Canadian Fellowship from Royal College of Pediatric Child Health in 1997. In 2001, he has certified in pediatric endocrinology by American Academy of Pediatrics and the Canadian Royal College. Prof. Al-Alwan led a number of research projects and secured grants from multiple sources. And he is currently a principal investigator in a number of ongoing studies. He lectured in various countries and published in different aspects of pediatric endocrinology and medical education. From administrative level, he is the president of Association of Medical Education in the Eastern Mediterranean region and an executive council member, World Federation for Medical Education. At national level, he chairs various committees, established the Saudi Pediatric Endocrinology Fellowship Program in 2004, and he served as Dean of the College of Medicine between 2010 to 2014. So very rich CV for Prof. Al-Alwan, and we will be delighted to hear from him some interesting cases as well. The floor is...
Thank you very much, Dr. Hussein. I'd like also to thank Dr. Prof. Asma Deeb for organizing this webinar and being our president, and had an excellent presentation this morning. I'm sorry to say this morning because I am currently in the western part of the world, and so it's still morning in our side. And I also thank Professor Argente for his excellent work in growth. He's unique. He's unique because he is an excellent clinician. At the same time, has a lot of sciences to discover the genetics of growth. We thank him for his presentation. And I'll move to my second part, just to say one word, that Argente is his family name, translate to silver, although his outcome of works is always gold. Thank you, Professor Jesus. So my presentation is about clinical path. 28 years of experience in pediatric endocrinology. I'll give you two only of interesting cases. We were, for sure, during our experiences, we met cases which we sometimes struggle with or gain a lot of insight about them. These are clinical cases. I'll give you a summary by the end of my presentation of them. What you see in the background is the Children's Hospital, Specialized Children's Hospital, King Abdullah, in Riyadh, where I work currently now. First case, we have Muhammad. He is a 16 years old Saudi boy, first seen at the age of 9, when he was referred due to concern about his height. Birth weight was normal. He had no chronic illnesses, no medications, no allergens. Was doing average at school, and his mid-parental height was 166. We when he visited the clinic, we confirmed the height of his mother. Father height was taken by history from the mother only. On examination, he looks well, normal vital signs, with a height of 119 and a weight of 18.5. Both fall at the 5th centile for his age. No dysmorphic features or abnormalities were detected, and he was pre-pubertal. These growth were plotted in a Saudi growth chart, and that, as you see on this side, that the height falls on the 5th centile. The question is, what should we do right now? We have options. As he falls at the 5th centile, he is not by definition a short stature. We reassure him and discharge him from my clinic. Or the second option is to reassure and just to see him in 6 months to evaluate his growth velocity, because he's already referred to our clinic. The third option is to do basic workup for any short stature. The fourth option is to start him growth hormone. I'm sure that most of you will agree with choosing only option, the first option and the second option only. I was leaning towards reassure and discharge from the clinic. Mother was insisting, so I gave them 6-month follow-up just to see his growth velocity. In 6 months, the interval of the 6 months, he had a remarkable history, medical history, and growth velocity in 6 months was 2 centimeters, which is normal for a pre-pubertal child. His current height at that visit was 121, so still at the 5th percentile. Mother and the patients were reassured. Mother was not happy at all. She was insisting to start him in growth injections. And why is that? Because he had a step-sister who was receiving growth hormone. Step-sister, so the father had more than one wife. And from the other wife, there is a sister who's currently in growth hormone in our hospital, which I don't know her myself. And the mother also insisted that all the uncles from both sides, maternal and paternal, are very tall. So now I was forced to go for option 2, which is to do the investigation and see them in 1 week. What we did the basic workup for any child with short stature. Thought that he falls within lower than the mid-parental height, as mother mentioned. CBC and ESR, thyroid function, urine and creatinine were all normal, and Celix cream was negative. The only thing was of a concern that the IGF-1 was in the lowest normal for his age. IGF binding protein 3 was normal. And we did for him bone age at the age of 9, which showed it was equal to his chronological age, and that his predicted adult height from that bone age will be 162 centimeters. 162 for an adult person from CDC growth chart is normal, and also falls in the 25th percentile for the Saudi growth chart. So the third visit, the mother was concerned still, although I reassured her, she wanted just give us 1 more visit. And so I gave her 1 year from 9 year and a half old. I saw him at 10 years and a half. No medical problems during the interval period. The growth velocity was not good. He dropped to 3.8 centimeters per year, which is less than normal. Is that a pre-pubertal drop? Maybe, but was also a concern. His current height at the visit when he was 10 years and a half was 124.8 centimeters, which falls between the 3rd and 5th percentile for the age. Still pre-pubertal. At that time, taking consideration the paternal, the family history of tall stature, and he's the only short one, and his sister, the stepsisters, without doing growth hormone stimulation test, a questionable idiopathic short stature professional diagnosis was given. A trial of growth hormone was started at the maximum dose of 40 mic per kg per day, and we followed him every 6 months. He was doing well. He was gaining height during that time until the age of 16, which was his last visit to the clinic. Muhammad was 16 years old. At that time, he was healthy. His height was 158.6 centimeter. And he had tenor stage 5, both gonads and pubic hair. What you see here in the growth chart, that the 158.6 in a Saudi growth chart is between 10th and 25th percentile, where in the CDC it is below the 3rd percentile. What was his bone age? Bone age was equal to his chronological age, which is 16. That means that all the epiphyses of the phalanges were closed. And that's an indication to stop growth hormone. So we stopped growth hormone. When I decided and tell the patient and the mother, they were very upset and they were unhappy about the current height. And I gave them the scientific explanation that no growth hormone can be used beyond the age of 16 for a bone age, because that will cause more side effects than any benefit. They were discharged from the clinic. Just to show you the difference between the CDC growth charts and the Saudi growth charts in brief. What you see in the middle, let me show you the pointer, a laser pointer. 3rd percentile for an American male will be around 163 centimeters, where in a Saudi 3rd percentile for a male will be 156. He's within normal range for a Saudi growth chart, but he's very short for the CDC growth chart. As a follow-up, mother, after a few months of the discharge from the clinic of Muhammad, she came in to visit me in the clinic. She was alone, and she expressed this major concern about her son. He was isolated. He does not attend any social activity of the family, and he even misses mosque prayers and occasionally misses school. And she asked for any other alternative method of changing his height. I told her I have none, because he reached his final height. And for him, as being symmetrical, no apparent genetic problems, I don't advise you for anything. And she insisted to know other information. So I've told her there is a surgical maneuvers which lengthen the bone, but that's not for him at all. She wanted to get second opinion, so I sent her to a well-known orthopedic surgeon in Saudi, in Riyadh, who's doing a lot of laser off lengthening bone procedures. He, at the same time, advised her that he cannot do anything for Muhammad, as he is normal otherwise. And he's almost normal for Saudi growth chart. 4 months after our talk and visit to the orthopedic surgeon, Muhammad went to a private hospital, paid 64,000 Saudi riyals, 64,000 Saudi riyals to do the lengthening of the bones, stayed in the hospital for 4 months. Unfortunately, although he gained height, he had bone infection, he had malrotation on the right ankle, and that's the end of the story for Muhammad. What went wrong? What went wrong with Muhammad management? Was it a problem of my diagnosis at the beginning or later diagnosis? Was it a problem of the assessment? Was it a problem of the management or treatment? I will take them one by one. We'll go through them. Idiopathic short stature is there. I mean, it is a disease in between the growth hormone deficiency and the growth hormone resistant. It's called idiopathic because we don't know, but it is well defined, accepted by all Society for Endocrinology. We know the definition. You have no explained underlying disease, but your potential height is less than your mid-parental height or your community. And that's what Muhammad was there. Should I brought the father, measure his height, and did a start growth hormone earlier? Maybe he benefited at that time. And the other part, which is very, very important, and the message from this case, is the psychological part. The child went isolation completely from the community, from his school, from his even mosque attendance. I'll give you a few slides about the importance of psychology in growth and height. Normal height. And let us talk about tall stature. Tall stature, this is a funny study claiming that the importance of US president election based on height. And it's a nice review article which showed that all one need to be a US presidential election is to be taller than your opponents. And the data was collected over years, and yes, correctly, that almost all presidential election height indeed is important factor for the US presidential election. What was the reason for that? The assumption that the perception was associated with the height, where taller presidents have rated as a greater and have more leadership and communication skills. That's normal, tall people. Let us see what short stature disadvantage studies currently prove. These are old slides, but to show you the same, known psychological problems with short stature. It is divided to 2 parts, during the childhood and during adulthood. In childhood, being juvenilized, teased by his colleagues and school, and the school bullying, also exclusion, loss of independence, and maybe overprotection, like the mother of Muhammad here in this case. Adult social isolation, perception of lower importance may also have limitation for certain jobs. And in Saudi, like pilots, the military pilots, they require certain heights. Okay. Review of the importance of psychological part of short stature in severely short children. This is an abstract summarized in these 3 columns. The first part of this abstract said that the data confirms that the severely short children are vulnerable to developmental, social, and educational problems. And they required a multidisciplinary treatment approach, and that the psychological part should focus on the academic achievements and also the psychosocial development. Very important for the severe short stature. What about the idiopathic short stature, not the severe ones. The review articles 2011 said that still there is a debate about the relation of psychological effect and idiopathic short stature, and that although literature review did not prove conclusive evidence, when the patients and parents, when probed individually, they report issues, especially in the social domain. So there is an effect of psychological part of idiopathic short stature. Also, just to be in scientifically correct, that this stress or social effect is not always implied in the height alone. It may be determined by other reasons. In Arabic, we say al-qasha alladhi qassat dhahr al-ba'ir. The person may had underlying problem, and being short was the one affected him more. Last part, that on this review article recommended the assessment of psychosocial criteria may become a factor in guiding treatment decision in patients with idiopathic short stature. We know that treatment of idiopathic short stature is proven by American FDA, but it's still not in the European countries. In Saudi Arabia, we do approve growth hormone for idiopathic short stature, the same criteria of the American ones. A larger study, more recent, from European countries, had the quality of life of idiopathic short stature and the effect of short stature on them. The summary of that abstract, that it's a large, containing 7 European countries, each between 8 to 18, and they had questionnaire for the parents and also the children. The parents showed more concern that there is internalization problems and low self-esteem. And when treated, the treated children self-report showed better quality of life than untreated group children. The recommendation of this review study is to say that these results suggest that children with current short stature are at great risk for internalizing problems. Last is the European Society of Pediatrics 2017 recommended that we do each patient with idiopathic short stature, not to take, the general belief that parents are more affected by short stature than the children, but that we need to assess each patient physical and psychological burden. And that will affect our decision to start or not start growth hormone early or late. So that's the second part, which is the impact psychologically. The last part, did I gave a late growth hormone, or growth hormone should be increased, the doses? Let us see here what's the recommendation for idiopathic short stature and the recommendation for treatment. What we say, we have to always to balance that the rationale about treating children with idiopathic short stature to increase the height, elevating the psychosocial disability while maintaining risk-benefit favor, cost-benefit favor. The thing which is very important in increasing height is idiopathic short stature, and we always, as endocrinologists, should counsel the patient and the parent about it, is that the height of the patient will increase, but he will not be tall. So do not expect that the height will be 175 or 180. He will gain height, he will improve than his current height, but he will not be as very tall. It's not a cosmetic treatment, it is improving the height only. Last part of this case is the dose. This case, Muhammad, I last saw him 10 years ago, so that's time where the 40 mic was recommended. Now you may add, you extend the dose beyond 40 mic per kg per day, providing that the IGF-1 levels do not exceed third percentile, positive third percentile for the age, without side effects. So normally we keep them until 2 standard deviation above the mean, but you can reach up to 3 percentile above the mean, standard deviation above the mean, provided that you don't have a side effects and you're still gaining better height. That maybe helped him if we did. This is the summary of the case, that you have to do individualized psychological assessment for cases like Muhammad. I remember now that Muhammad, during all his visit, didn't say a single word in my clinic. It was always the mother who was talking. And never at any visit, Muhammad came with his father. Was always the mother, the one who brought him to the clinic. I should also told the mother that he will gain height, but he will not be tall. But maybe that was a concept they did not gain, and then we failed to avoid that surgical experience he had with the complications and the money they paid. We move now to the last case, which is the second case. Tahani is a Saudi female, 8.5 years. She was referred because of short stature or concern about short stature. She was a product of full-term and interval pregnancy. Birth weight was normal. Length also was normal, no neonatal problems. She was always shorter than her peers, except with a slight improvement of her height during the last 6 months. No chronic illnesses, no allergies, no medications. Family history of short stature and maternal grandmother. She was doing well at school. In her examination, Tahani looks well with normal vital signs, no dysmorphic features. Her height was 120 centimeters, which in a Saudi growth chart falls between the 10th and 25th percentile. No asymmetry, systematic exam was normal. Her mid-parental height was 156 centimeters, which is normal for females. Now I'll ask you a question, and because of time, I may suggest for you the answer. Before that, the referring physician did the basic labs for short stature, and all were normal, including CBC, SR, thyroid, bionic creatinine, celiac was negative, IGF-1 and the IGF-binding protein 3. I'll go back to the case that Tahani current height is between the 10th and 25th percentile. Which of these options we will check? Option of reassurance discharge from the clinic, reassurance follow-up in 6 months to assess growth velocity, or do the basic workup, which was done by the referring physician, start growth hormone, or others. Okay. Because of the time, I'll go for the others. I'll tell you what's the others. I think we still have some of the clinical assessment missing. What are the missing parts which we did not gain from the presentation of mine? The issue is we did not ask about puberty. Although I did it, but for the sake of this presentation, I show you that she was noted to have breast tissue developed for the last 8 months. So she was just before 8 years of age, and she had pubic hair for the last 4 months. No menarche yet. Pubertal tunnel staging. Breast tissue was T3. both breast, and pubic hair was 10 on stage 2. And we see in the right side that her growth chart, she was always at around 3rd percentile, and lately she increased up to the 10th percentile for her age in a Saudi growth chart. So that's an important part of the history. I will go back to the other options, investigation. Should we do other investigation? Having or knowing that she had pubertal signs, I did the basic workup before any stimulation test for LH, FSH, and estradiol, and all were suggesting that she's in puberty now. I mean, confirming that her clinical examination of entering puberty, LH of 2.2, FSH 4.6, and estradiol of 92. Her born age at the age of 8.5 was 10 years. So she had an advanced born age. What is your recommendation now for treatment? If we go back for therapy, I elected, although she's normal for that growth chart, but she is going to fall short if we did not treat her. And the treatment was to stop her puberty by giving her gonadotropin-releasing agonists, and we had the 3 monthly injections, and we started her in growth hormone 40 micrograms per kg per day. What's the message from Tahani case? Growth chart. See the Saudi growth chart. For an adult female, Saudi growth chart, 3rd percentile is 144. This is a growth chart of the all Saudi population, including 42,000 children was included in the study. But they are from all parts of Saudi Arabia. And we know that there are certain pockets of Saudi Arabia, the tribes, they are very, very short, normally short. And so the message is growth chart as to help and support you to assess the growth of children, but you need to do different steps in 3 situations. The 3 situations, including the first one, is the family height. If they are way below the mid-parental height, expected final height, so you do not take your national growth chart as the main one. And second part is if they have a syndrome like Turner syndrome, Down syndrome, achondroplasia, they have their own growth chart. So you have to apply them to their growth charts. And last, an important part, which is our scenario here with Tahani, is the adjustment for pubertal maturation. We need to have a growth chart which is specific for an early pubertal entry. And currently, the CDC or the European ones, or the UK, the WHO UK growth chart, they are mainly cross-sectionals. They do not take consideration the pubertal maturation. The growth charts, as I said, is cross-sectionals. They do not give you a proper projection of adult height if there is an early puberty. The Saudi growth chart, along with the common major growth charts in the world, CDC, WHO, and UK, are based on cross-sectionals with their problems. I'll tell you some for the CDC. The CDC, they started with the older version by collecting data from different studies, different timing. The first one from 1963-65. Second one was from 66 to 70. And another one from 1971 to 74. They collected all these data, they put them together for different ages, and they made the CDC. CDC 1997. Then, because of a problem from the younger ages of 1997, 1977 CDC, because of that the study was mainly formula-fed white children from certain part of US, they updated the CDC to the latest one, which is CDC 2000. So growth chart to support, but growth chart alone are not patient-specific. Let me tell you one more thing, that when they take the cross-sectional data, they have to apply a statistical correction of the number. So they do not come smooth curve. They have to have program which smoothen the lines. So that's always a problem. Let us see the availability of Turner stage height for age percentile chart, which is a chart taking consideration early puberty. If you see here, the one in dotted black is the CDC normal children pubertal entry, or the red solid line, the ones with early puberty, with Turner stage 2. There is a clear higher height early on the earlier puberty, with a lower final height and earlier stop of height. So this is what we're supposed to use for our children who had an early puberty, to make an exact final height and to make a decision to treat or not to treat. This chart to give you also a difference between boys and girls, and the difference when they enter puberty, Turner stage 2. Very early, they usually end very short compared to the norm of the US population. And if they start later but a higher height, they may catch a normal height within the community, both for the boys applied for the girls. Is there a limitation on this growth chart, which is based on pubertal assessment? Yes. We know that the original Turner staging was done by Marshall and Turner, was based on London, was based on white population. They were poor, low socioeconomic class, and they were based on inspection only. There was no palpation and assessing puberty for breast tissue, nor for the gonad size. What was done on the American pubertal staging growth chart, they did assessing the secondary sexual characteristic for female for the best stage, but for the male, they assessed the gonadal size by only inspection without using palpation or codimetry assessment. So that's another limitation. Coming to the end of my presentation, the take-home messages. We had two cases. The first case, that you should have assess each patient physical and psychological burden to decide for an early treatment or not to treat cases of idiopathic short stature children. Painful to see Muhammad going through surgical procedure with a complication, and also paying a lot of money. Second message is that idiopathic short stature, that you have to convince and tell and counsel the patient and the parent that your child will grow better, taller, but he will not be tall. So that's from the beginning before you start therapy. And it's not a cosmetic, rather than just to improve the height a little bit. Last message from the second case is that we need to adjust the growth based in cases for early puberty. There is an available growth chart currently from the US, but can be applied at least for your children who had an early puberty until we have our own growth charts. That's the end of my presentation. Thank you for your attention. This is a picture from Hokkaido, Japan, this last winter I took myself. Thank you.
Thank you very much indeed, Ibrahim, for this. It's really nice to see or to hear from Prof. Argente this very academic, high-level research, but also we need not to forget what we see on day-to-day clinic and how the parents' counseling can be really challenging. There are many questions posed to you, Ibrahim. We only have 5 minutes left, so we need, if you don't mind, precise answers. Jesus and Hussein, please go ahead and comment if you have anything to say on Ibrahim's cases. Majority of the questions were related to your first presentation, and many people are asking, you labeled the child as a case of idiopathic short stature, even though you didn't do growth hormone stimulation test and you did not exclude growth hormone deficiency, yet you called him or you defined him as idiopathic short stature. Can we have a short comment on that, Ibrahim?
Yeah, the correct definition that we have to have growth hormone stimulation test. Just to tell you that we, in our hospital, it comes time to time based on the testing. The testing is done in the short stay in the hospital, which is 1 day admission. And the waiting list may sometimes goes to 7 months. And in a child who was 9 years and a half, and waiting for another 7 to 8 months was a burden on me and on the parents. So I elected to say that he might have a normal growth hormone because of his IGF-1, IGF binding protein 3, and also the bone age, which was not delayed. I know it's not the most appropriate, but that was my rationale of starting him in growth hormone and labeling him as idiopathic short stature.
One more question, and then I will invite Hussein and Jesus to comment. Now, the issue, we know very well, and you showed us great evidence about the correlation between short stature and depression, which can be even clinical depression. But again, and it's very easy to be clever retrospectively, but I do recall many patients, at least one child during my training, where he presented with depression and his growth chart was similar to yours, and this child ended up having a slow-growing glioma, leading to growth hormone deficiency. So we are all clever retrospectively, but I think, and we see many of patients like you showed, but I think we perhaps consider why this child had features of clinical depression apart, because he wasn't extremely short to have the psychological issues. I mean, his 166 or that's pretty good for Arab children, but to have those social avoidance and what looks like clinical depression might sometimes prompt us to see whether there's something ongoing. I'll let you comment on that, and then we would love to hear from Jesus and Hussein, please.
He was 158.5, so it was short. And the concern now for the Saudi pediatric endocrinologist, just using the growth charts, that it might be very general because it took all the regions and put it in one growth chart. We're supposed to have regional growth charts, and we make also consideration of mid-parental height part of the assessment, not to leave the mid-parental height out of consideration. Yes, Prof. Jesus?
Yeah, thank you very much. So Ibrahim, regarding your first case, I think that we all are medical doctors, are pediatric endocrinologists, and therefore we need to take care of our patients, and we need to consider any comment from the parents, in this particular case from the mother. We need to analyze the country where we are living, the intellectual level of the families, the possibilities, the kind of nutrition the kids are having, etc., etc. So connecting with Asma comment, I think that if you have a reduction in growth velocity at this age, of course, it could be a constitutional delay of puberty, but in my opinion, an MRI should be done in order to make sure that there is no, not only an astrocytome, but also craniopharyngiomas that we can diagnose at this moment. And if you have seen many patients, I'm positive that we had some experience with patients like that. So otherwise, I guess the diagnosis was, the orientation of the patient was correct. Whether to treat it or not, we cannot treat it in the European community because the idiopathic short stature is not an indication. When I talk to people treating patients with ISS, it's always the same thing. There is not an international concept. So you have done just a regular biochemistry. You have seen that this patient is not a celiac patient. And you have seen that IGF-1, IGF-3 levels are normal. And therefore, you could potentially consider that this is an ISS, but I really don't know what this patient has. But if you have the possibility to treat it in your country, well, you get a good response. And of course, the last part of the story of the patient, I don't know if he passed away or not with the infection in the bones or not.
No, he was okay.
Oh, okay.
He was fine. He was fine. Yeah.
He was fine.
Yeah.
But anyway, I wouldn't ask a guy with a bone age of 16 years old with most of the bones already closed to have surgery at this moment. And regarding the second patient, I think that of course it is important to, if you make the diagnosis of precocious puberty, either central or peripheral, with basal LH levels, there is always a problem to know what kind of assay your lab is using, because 2.2 of LH with 4.2 of SH, well, could be normal, could be prepubertal, depending on the kind of assay you're using, and an estradiol of 92 picograms ml should, in my lab, will be very elevated. So the concept of precocious puberty is clear, and you can discuss whether or not to perform an abdominal ultrasonography to see whether you have any kind of cyst or anything in the ovaries, or to perform an MRI, which is obviously discussed. Is always, it should be done in all boys, but some people consider that in girls due to the fact that the majority of them, they do not exhibit any problem. But I would do that. Anyway, I will treat them with Generates analogs, of course. And if you have the possibility to add growth hormone, because also this is not internationally in accordance for everyone, in order to treat, to stop puberty and to increase growth with growth hormone, I would do that. If you cannot treat with growth hormone, I would treat with Generates analogs in order to stop puberty, because these ladies. And my final comment, I was, I don't know when your charts were done in your country, and it's a longitudinal study or a cross-sectional one, if it's if your charts are old or not. But I am impressed because the centile 50 of your girls is about 10, 12 centimeters less than in Spain. And I think this is too much. And I don't know whether the charts are done with an heterogeneous population, with different degrees of nutrition, intellectual levels, etc., which is something important to put clearly the picture of a country in terms of growth. So if they are old, I think that probably it should be better for you to create a new charts to reflect the reality of the Saudi population at this moment.
Thank you for the comments. I have three answers for the three comments. Prof. Asma, Deeb, yes, Muhammad had an MRI, which was normal, because I prepared my presentation during my vacation away from my office. I don't have the MRI, but he had a normal MRI. The second part, which is the labs norm for puberty, these are high for our lab standard, and they are pubertal levels. For the question of precocious puberty or not, I did 2 school studies in Saudi Arabia about pubertal staging, and on females, we tend to have an earlier puberty like the African American girls, and so 7.8 years of age is considered norm for our population. And so she was 7.8 year, or she was 7 and 10 months when she had her first breast tissue. So I was not concerned because her grandmother, who was also short, had an also early puberty. That's
Okay.
for that answer. Last but quickly, the Saudi chart was very good randomized, cross-sectional, contained 42,000 children, but the problem is that they mixed all the regions together. So there was a clear difference between different regions, different tribes in Saudi. So I am now currently writing a proposal for a new growth chart. Hopefully it will be done in the coming few years. Thank you.
Good. Very good. Thank you. Thank you very much.
Hussein, do you have any comments before we close?
Interesting, but just before closing that, I have a comment about using different growth charts. So I know that the Saudi population, as Prof. Al-Alwan mentioned, in Oman, we have a similar kind of phenotypes of people compared to the Saudi, but we use the WHO charts because, as you know, that the WHO, when they start doing the growth charts, involves 6 countries, including Brazil, Ghana, India, Norway, USA, and Oman. So Oman was included in the 8,500 children studied to perform the growth chart. So we use the WHO growth charts, but again, there's always an invite to do the Oman growth chart with bigger cohort of children.
Can I comment on? Yeah. Can I comment on that, Dr. Hussein?
Please.
The WHO had 2 charts. The 0 to 5 was a longitudinal international studies, including Oman, but that was only for the age of 0 to 5. And beyond 5 was also cross-sectional. So they did not do longitudinal studies beyond the age of 5, was a cross-sectional. So when you use a WHO for the age of 0 to 2, it's excellent. Even the American are recommending that 0 to 2 to use the WHO. But beyond the age of 2, it is like the CDC, like the UK, like the Saudi ones. It's the same because cross-sectional. Yeah.
So
very important point.
There's an initiative for ASPED to run new growth charts for our.
Yes.
What about head circumference charts? To what age do you have
2 years.
head
2 years.
circumference chart? Yeah,
2 years.
so that was my question to Jesus. I don't think you got my point, Prof. Argente, when I said, how would you diagnose microcephaly above the 2 years? Which charts would you use for those?
As my answer was clear, we use Spanish charts because we did a longitudinal study, and we modified this longitudinal study recently for a second one. And then we have weight, we have length, height from 0 till 18 years old. We have curves specifically for newborns. And also we have, of course, BMI and head circumference. Those are the parameters. And of course, we have a number of other parameters, including setting height, etc., for specific things. And of course, we are working in a specific chart for Turner syndrome, achondrodysplasia, etc., in these children. So,
Okay. I think we came to the end. It took a little bit longer before I hand over for the very final words, I'd like to thank you very much indeed, Prof. Al-Alwan and Prof. Argente, for these very nice, stimulating discussions. I would like to thank Pfizer for sponsoring this webinar, and of course, thanking you, Hussein, for everything. Long list for why I'm thanking you, but thank you very much for everything, as well as for our colleagues who attended this webinar during their weekend. Last word, Hussein?
Thank you very much, everyone, and stay tuned. We have a number of webinars coming for next month and the month after, so follow us on either the ASPED What's group or ASPED social media handles or the website. Today's webinar will be edited a little bit if some patient details will not be appearing, but the main messages will be posted. So follow us on the ASPED website.
Thank you.
Thank you very much. Have a great day or night or evening, wherever you are. Thank you very much.